Now, moving on to further more life-threatening injuries, we are discussing the chest trauma. We have discussed briefly the other such as simple pneumothorax, tension pneumothorax, massive pneumothorax, failed chest, and tracheobronchial injuries. But we'll be discussing some of the other life-threatening injuries such as cardiac tamponade, tracheobronchial tree injuries, and traumatic aortic disruption in this section. So, what is cardiac tamponade? Accumulation of blood within the pericardium, restricting its ability of the heart to refill, resulting in loss of cardiac output, leading to pulseless electrical activity or cardiac arrest. We know that around the heart there is a layer of pericardium. If that blood gets accumulated in the pericardium, this leads to cardiac tamponade. So that the heart cannot pump enough blood because it cannot actually expand and contract properly. This way may lead to eventually hypotension and cardiogenic shock. It's associated with usually penetrating trauma, especially the stab wounds between the nipples of the line and the scapula, or usually the gunshot wound towards the center of the chest or the mediastinum area. There is how to make the diagnosis of cardiac tamponade. There's especially triad, which is very important to know and to recognize, especially when there is a gunshot wounds around this area. You must be think whether the patient may be suffering from cardiac tamponade or not. Although it's difficult, but sign can be subtle, but we have to very make sure that what is the Beck's triad, and it's actually a triad composed of three things. That is distended neck veins due to elevated venous pressure. The patient is having distended neck veins, muffled heart sounds, and fall in the arterial blood pressure or hypotension. This is usually a classical presentation of cardiac tamponade. If the patient comes with a hypotension and shock, and there is a muffled heart sound and there are distended neck veins, then the first thing we should be thinking of is the cardiac tamponade. Usually, the treatment is this all sophisticated imaging, CT scanning, MRI, EFAS, and transesophageal endoscopy usually are not indicated straight away because the patient is not vitally stable. Once the patient can be stabilized, then we can go for all these sophisticated imagery to recognize what is the possible cause of the or how much extent of damage to the myocardium has actually taken place. The management is basically relieving pressure within the pericardium. That is simply draining the accumulated blood, hemopericardium which has accumulated, and stopping the source of bleeding and prevent reaccumulation. Immediate surgical repair is only done if the patient is not getting stabilized despite being the pericardiocentesis being performed. Therefore, maybe the rent in the myocardium is massive and probably we will require a surgical repair. Usually, a needle pericardiocentesis, that is, a needle is passed through the xiphisternum into the pericardium, a large IV bore cannula, and actually the blood is drained off the pericardium. This is usually enough, but if despite being doing this, the patient is not coming out of the pericardial shock, then probably we may have to go for a surgical repair as well. Pericardiotomy via clamshell thoracotomy may be required, but this is usually the case when there is actually extensive myocardial damage as well. Therefore, once we have to go for open heart surgery, that is usually the damage is already very severe and that is associated with high mortality and high morbidity. Now coming to the tracheobronchial tree injuries. These are also subtle injuries, but usually do not maybe life-threatening initially, but eventually can still the patient have a lot of problems with the ventilation, and patient may remain in intensive care for a longer period of time. Usually, chest crushing injuries are associated with upper airway injuries, mainly within the 2 cm of the carina. Carina is the point where the trachea divides into right and left bronchial tree. Usually, they present with hemoptysis, surgical emphysema, simple or tension pneumothorax. Now, we have dealt with simple pneumothorax, but there is a simple pneumothorax persists for a prolonged period of time with hemoptysis and coughing of blood by the patient, surgical emphysema. Then we must be thinking whether there is tracheobronchial injury or if there is a tracheobronchial fistula, which may be a patent communication between the lung and the bronchial tree leading to these kind of symptoms. CT or MRI is usually ideal for the diagnosis, but bronchoscopy is also used to diagnose whether where is actually the bronchus is involved in this formation of tracheobronchial fistula or tracheobronchial tree injuries. Coming to the treatment is use of large chest drains, could be one or more sometimes, so that high volume and low pressure pumps can be utilized and allow lung reinflation. But if it persists in form of a persistent bronchopleural fistula, then probably requires an operative intervention. We need to repair the area so that the continuous pneumothorax does not remain and lung reinflates. Now coming to the blunt cardiac injury. Also, this is another follows a direct blow to the anterior chest during a trauma. For example, the handle of the car got hit, patient's chest got hit to the handle of the car. This may lead to blunt cardiac injury associated with fractured sternum as well, and usually results in myocardial contusion, chamber rupture, could be valvular disruption, hypotension, conduction abnormalities, dysrhythmia, and ventricular fibrillation. So actually the injury is not maybe initially present, but this may manifest as ventricular arrhythmias, tachycardia, and hypocardiogenic shock. So the management mainly includes supportive treatment. Patient should be monitored for at least 24 hours and ideally in coronary care unit or CCU, following which risks may be associated with sudden dysarrhythmias. They must be diminished substantially, and we should be on the lookout for development of arrhythmias, especially following a blunt cardiac injury. Now coming to another rare but highly life-threatening injury such as traumatic aortic disruption. Although if the disruption is not contained within the certain parameters, eventually the patient dies before even reaching the hospital. But if it is a blunt aortic injury, usually associated with decelerating injury, this may be during a high-speed road traffic accident, which is mainly in the proximal thoracic aorta. This is once the descending aorta starts in the proximal thoracic aorta area. This is where the most commonly it occurs. This complete transection or rupture is highly catastrophic, and this will lead to death. But sometimes hematoma can be contained. What results in is a partial rupture, and hematoma actually contained in the adventitial layer of the aortic wall. These are the actually patients which eventually reach hospital and get some treatment, because if there is complete rupture, the traumatic rupture of the aorta is usually a death at the spot. But if somehow this disruption is incomplete and hematoma is contained in the adventitial layer, then what are the signs symptoms this patient may present to us? These include the diagnosis can be made by angiography, which is the gold standard diagnostic tool for the traumatic aortic disruption. Although CT scan can be used with contrast, but usually CTA, that is CT scan angiography, is ideal. Chest X-ray are helpful in diagnosis. It usually have certain findings. For example, there's a wide mediastinum, if you can appreciate it over here. If you can appreciate more, there's no aortic knuckle. That is, arch of aorta is actually lost because of widening of the mediastinum, and you get deviation of the trachea towards the lesion. If the problem is on the right side, the deviation of trachea, if you see it over here, is usually towards the opposite side. If the problem is over the left, the trachea deviates toward the opposite side. In this, we have briefly gone through some of the other life-threatening injuries, especially associated with chest trauma, and cardiac tamponade is one of the most common life-threatening injuries, and we must be on the lookout because usually the findings are very subtle. We must remember the background, that is hypotension, distended neck veins associated with muffled heart sounds. This is one of the very classical scenario for the cardiac tamponade, and pericardiocentesis can save a person's life. Although other life-threatening injuries which may not be life-threatening initially include tracheobronchial tree injuries, but the problem is the persistent tracheobronchial tree injuries can lead to bronchopleural fistula, which may eventually need thoracic surgery, which may be required to actually deal with the bronchopleural fistula. And then a very rare condition which may be associated with decelerating high road traffic injuries such as traumatic aortic disruption. Complete rupture is catastrophic and patient may die before reaching the hospital, but in case of partial rupture, sometimes the hematoma is contained in the adventitial layer, and maybe a surgery may be required to repair the aorta properly. Thank you very much. Keep watching sqadia.com.